All right, good afternoon. Oh, we got to do better than that. Good afternoon. Okay, that's much better. I'm a son of a preacher, man, so I have to get it. All right. Well, it is an honor and a privilege to serve as moderator for our third CME session of the day, which is titled Primary Care, Promoting Health Quality, Longer Lives. Before we get started, I would like to introduce myself. I am Dr. Frank Clark. I am the current chair of the AMA's Minority Section Affairs Governing Council. By trade, I'm a psychiatrist who practices in Southwest rural Virginia. I practice in an inpatient setting, but also I split my time between inpatient and ambulatory care. I see a wide range of patients from those battling depression, bipolar disorder, anxiety disorders, and psychotic disorders, as well as co-occurring substance use disorders. So this is a topic that is important, given that there's a lot of intersectionality when you talk about primary care and behavioral health. So basically, each of our panelists, which I'm happy for them to be a part of this session today, will have 10 minutes to present what they're going to talk about. I think it's going to be this will foster a healthy discourse, and we will save questions for the end. Each panelist will have 10 minutes to present, and then again we will take questions. Before we begin, some of my opening remarks, I wanted to just touch on, the importance of the racial gap in life expectancy. I was reading a report by the CDC back in 2013, and this report highlighted some astonishing, kind of staggering numbers. So we know that healthcare disparities influence life expectancy. I think everybody knows that and would agree with that. What this report showed was that higher death rates among the African Americans was due to heart disease, cancer, homicide, diabetes, and prenatal conditions. As we know that life expectancy is increasing, but we also have to look at the facts. So based on a report in 2010, it was found that African Americans in general had a 3.8 years lower life expectancy compared to white populations. If we look at black males, 4.7 years lower. And if we look at black females, 3.3 years lower. When I think about high quality and longer lives, we have to talk about a lot of things. Obviously, we want to achieve health equity, but how do we do that? When I was meeting at the roundtable discussion yesterday, one of the things that I think is important that we often neglect is health literacy. Oftentimes, we make the assumptions that our patients are literate. We don't take into consideration their education level. We don't ask always the right questions. We assume that if we say, take your medications twice a day, that they know what that means. Oftentimes, we are mistaken. If you look at data from the American Public Health Association, 75% of the U.S. greater than 50% of the U.S. is affected by health literacy. 40% of African Americans have difficulty reading. 20% of Spanish-speaking Latinos do not seek medical care because of language barriers. And the statistics go on. So with that, I'm going to introduce my colleague and friend, Dr. Niva Lubin-Johnson, who is the immediate past chair of the AMA's Minority Affairs Section Governing Council. I have known Dr. Lubin-Johnson for over 7 years now. When I was a resident representative to the Minority Affairs Section Governing Council, she has been a mentor and a close friend for me. She is definitely a pioneer in her community, and not only at the state level, but at the national level. Dr. Lubin-Johnson comes to us with 25 years of experience in terms of medical delivery and practice in internal medicine. She is a Renaissance person by every sense of the word, and is probably on every board or committee you can imagine. Some boards I didn't even know she was on until I read her CV. So that would include, again, immediate past chair of the Minority Affairs Section Governing Council, president of the Cook County Physicians Association, board of directors for the Southside branch of the AANCP. So, Dr. Lubin-Johnson.
Good afternoon, everyone. And I know it's tough after lunch, but hopefully you've had some caffeine too, so you'll be awake this afternoon. So I'm going to speak to you today about promoting high-quality, longer lives through PrEP for HIV among minority women. PrEP is pre-exposure prophylaxis for HIV, and so that's what I'll be speaking to you about this afternoon. Point where screen. Oh, no, that was the whole yeah. There we go. Okay. That might have been the second slide. Let's see. There we go. All right. So as an overview, probably the first one you can't see well, but 1 in 5 new HIV diagnoses in the U.S. are among women. 64% of women living within the U.S. With HIV are African American, though we are only 13% of the female population. And CDC estimates that 468,000 U.S. women are eligible to be on PrEP therapy. Women's healthcare providers are unusually positioned to screen and counsel about prescribing PrEP for women who need it. So providers, patients, and PrEP. Women in the United States account for, like I said, roughly 1 in 5. 87% of these are attributed to heterosexual sex and 13% to injection drug use. Those with an AIDS diagnosis reported among women has more than tripled since the beginning of the epidemic, from 7% in 1985 to 25% in 2014. Approximately 1 in 4 people living with HIV are female, and of those estimated to be diagnosed with HIV in 2015, 61% were African American. African Americans and Hispanics represent 30% of all women in the U.S., but account for approximately 80% of HIV cases among women. In 2014, 3.5 times as many black women were diagnosed with HIV as white women, and in 2015, black women were approximately 16 times more likely to receive a diagnosis of HIV infection than white women. So as you can see by these statistics, there's definitely a need to help prevent the transmission of HIV in women of color. So what can we do as providers? Talk about sexual health with each and every patient, discuss contraception and family planning, because PrEP can be given to prevent transmission if someone is planning on a pregnancy to prevent them from getting HIV. Promote testing and connecting patients and partners to care. Explain the therapy as treatment and prevention. And use communication, of course, to reduce fear, anxiety, stigma, reduce health disparities among women of color, and improve patient outcomes. So what is PrEP? It's a single once-a-day pill manufactured under the name Truvada, which contains 2 medications, tenofovir and emtricitabine, over 90% effective at combating HIV, exactly 92%, especially among the most vulnerable populations of women and patients who identify as gay, bisexual, or transgender. It allows patients to choose to make their sex life safer and take control of their sexual health and wellness. Has minor side effects, most commonly nausea, fatigue, dizziness, maybe headache, but usually those side effects go away after the first month of therapy. Who should get it? Women who are cisgender, meaning they identify with the sex they were married with, or transgender. Women who don't always use condoms during anal or vaginal intercourse, women who've been recently diagnosed with the STD, women who are unsure of the HIV status of their partners, those who are in a relationship with an HIV positive partner who may or may not be on HIV treatment, those who inject drugs or in a sexual relationship with someone who is an IV drug user, and pregnant women. So how can we approach this? How can we help? We can take it from a structural basis, a community basis, and to the individual. So how can we make a difference as physicians? Structural AMA policy. So you consider the issues around PrEP and its usage, collaborate across the NMA sections, develop resolutions, minority affairs section, of which Frank and I Dr. Mitchell, whom you hear from today also, are members of the Governing Council, the Advisory Committee to the Board on LGBTQ issues, the Women's Physician Section, Medical Student Section, and also collaborate with our professional organizations, ACOG, ACP, AAFP, etc. And by the way, not so shameless plug, that's a picture of the Mosque Governing Council, I think, from our interim meeting. Anyway, all right. So, recent policy. Just last year, AMA passed policy about PrEP. And AMA will educate physicians and the public about the effective use of PrEP for HIV, including use in women and minority populations, and the U.S. PrEP clinical practice guidelines, and AMA supports coverage of PrEP in all clinically appropriate circumstances. So what has been done along those lines? One, last year at our annual meeting, there was a CME session on PrEP and why and to whom during that session. Also, I participated in a meeting along with Dr. Mitchell with Haymarket Medical Education Corporation, had a meeting of various entities that represent all aspects of the population concerning the usage of PrEP and what could be done to expose more persons to it. Let's see. Oh, sorry. No, that's it. Okay. Also, there have been some other resolutions that have been passed in terms of HIV/AIDS education and training. More here. Published articles in the Journal of the AMA also concerning PrEP or testing strategies, et cetera. Community approach. I'm from Chicago, and so there are various entities we can partner with. Of note, kind of in the middle of there, is Howard Brown Health. So Howard Brown was founded predominantly as an entity for the assistance of helping those mostly men having sex with men in terms of helping with decreasing the transmission and increasing the treatment of those with HIV and AIDS. They actually opened a facility in a shuttered, look at number 2, Chicago Department of Public Health facility in Inglewood, a predominantly African-American, lower middle class, lower class community in Chicago, less than a year ago, actually. And actually, I have a friend, a church member, who's a nurse practitioner who works at that facility. Individual approach. So, various campaigns, ways of getting out the message to women about needing to use PrEP. And so some questions to think about. I won't belabor those. I'll let you all look and come up with your own for later, because I want to help keep us on time and hopefully get us back on schedule. Thank you.
All right. Thank you for that wonderful presentation, Dr. Johnson. All right, our next panelist, I'm happy to introduce, is Dr. Elizabeth Ofili. She is a professor of medicine and cardiology and senior associate dean for clinical and translational research at Morehouse School of Medicine. She is also the recipient of over 50 scientific services and health policy awards. She's an elected member of the National Academy of Medicine. Election to this academy is considered one of the highest honors in the fields of health and medicine and recognizes individuals who have demonstrated outstanding professional achievement and commitment to service. Dr. Ofili.
Thank you, Dr. Clark.
You're very welcome.
Good afternoon, everyone. So it is really my honor to be here today. The topic, democratizing discovery health with N equals me, is a topic we chose because of what happens, and you'll see why this is relevant to this notion of primary care, promoting quality care and longer lives. So these are my disclosures. I am the lead inventor of system and method for chronic illness care. And this is associated with a faculty startup. The patent came out of Morehouse School of Medicine. So I just want to introduce you to FNO. She happens to be my mom, and she's sitting right there in the audience. So wave, 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 Mom. I have her permission. So she's 76 years old. She has hypertension. She was diagnosed with diabetes in 2011, was devastated with that diagnosis because as far as she thought she did everything right. She's a retired nurse. An A1C of 11 was not what she was hoping to find on her annual exam. So, as this thing gets back in, okay, thank you. Needless to say, we were all very concerned, and so Dr. Pimu, who's in the back there, and you'll get to meet her in a little bit, got her started on a program with a health coach, and next thing I know, I come home one day, she says, Frankie is coming. She's very excited. I said, who's Frankie? She says, that's my health coach. I said, why do you need a health coach? Oh, Frankie is going to help me with my diabetes. And every time I would come home, she's excited. Frankie's there. They're talking. They're sharing recipes. And she'll show me, see those dials up there? Those are her blood pressure, blood sugar numbers. If it is 131, it'll go into the orange zone. She cannot tolerate that. And she tells me, Frankie says it can't go into orange. I said, well, Mom, I invented this algorithm. It's okay if it slips into 131. But this is just to tell you how powerful coaches are. It doesn't matter whether you're a doctor or not, a coach is powerful. And so this brings us to the issue of chronic illness care. You heard the statistics already, and I'm not going to spend a lot of time with that, but needless to say, lots and lots of Americans are affected, and low health literacy only complicates the problem. This is a program that we implemented, really, I should say, Dr. Priscilla Pimu, who really, as you can see, is the reference author there. She should be the one here giving this talk. I am sort of an imposter, if you will, a cardiologist dressed in primary care clothes. But, you know, this is a sort of, we believe this is a multidisciplinary approach. She basically went to Big Bethel AME Church, a historical church in downtown Atlanta, took this technology and implemented it. What you see there, that blank screen, it's actually a computer kiosk where the health coach to her right, the woman on the left is diabetic, and they were able to help her with her diabetes. And this was a program that was run out of Morehouse School of Medicine, sponsored by NIH with Dr. Pimu as the lead investigator. And this led us to the technology called Health 360 Acts, and it's out there. It's a shameless plug. We are trying to make sure people have an opportunity to use it. It is free online. You can download it and help manage your care. And basically, these are just simple messages that is there online. Atuara is sitting out there, so he can tell you everything you need to know. So just to save time, I'm going to go through this. This is what we do with patients when they don't have Atuara in person. Basically, the technology, anything you can measure, can be quantified and essentially translated into a very simple dial that communicates how you're doing. If it's green, it's good. If it's red, it's bad. And if it's orange, it's getting there. And whether it's blood pressure, whether it's blood sugar, whether it's your nutritional status, whether it's your physical activity, all can be measured. And basically accumulates that over a 90-day period, so you're able to share this information with your provider, and really cuts down the sort of incomplete information of a standard primary care visit. This technology is actually based on a very solid theory-based behavioral change model that is known as the COM-B system. And this system essentially says for a patient to be able to manage their health, they have to have capability, they have to have the motivation, they have to have the opportunity. And we took all of these parameters and integrated them into the framework of the model. And so in Dr. Pimu's study, she looked at 300 patients, and as you can see there, these were standard patients with diabetes, 65 years old, BMI, and had been sick for a while. And this is what was very interesting, and it really made had a lot of buzz in Atlanta, in the news. When you see the thing that you're looking at here is blood pressure dropped significantly over a period of 12 weeks. This is the 12 weeks of coaching, but even after coaching stopped, they were able to maintain the blood pressure. Glucose also improved, physical activity improved. And so the question was, How could we get there? These patients were mostly African American women, as you see, and Dr. Pima wanted to find out what are some of the things that were barriers here. It turns out that age was not a barrier, race, ethnicity was not a barrier, ability to see or usage of computer were not barriers. What were barriers actually was having level of anxiety about putting your information on the internet, as well as feeling comfortable about health information online. So both of them impacted how well individuals use a computer. And there was very interesting focus group and key informant interviews that really shed some important light in terms of why patients were successful. It had to do with empowerment, engagement, and if I had time, I would read some of this and also actually read them well, but I never seem to do as good a job as the patients themselves. But basically what you're seeing here is people are looking at this as a way to connect to themselves, to learn what's going on in their body and get that self-efficacy going on. They felt empowered, and really they started to understand, well, A1C relates to what I eat, and it makes sense. They were engaged because they had a sense that there's a peer community that they interact with that know exactly what they're going through, and essentially kindred spirits here. Coaches really inspired them to learn, and as I said, coaches are a huge part of the process here. So Health 360X did improve health and self-management behaviors among African Americans. The likelihood of being an engaged user was independent of age, years of education, computer ownership, self-rated ability to use a computer, and previous computer use. It was, however, significantly impacted if individuals had anxiety about their ability to use the internet, and they had discomfort about putting health information online. So that's why we think it's going to take not just putting the information online, but having a whole system of helping patients understand why this is important and what they should do to protect the information. At Morehouse School of Medicine, we work with community advisory board members who are members of the community. We also take a mobile unit out into the community and go across various rural communities. We partner with the community, this is really a very delightful opportunity. And we have a great team at Morehouse School of Medicine that really help create also this online process. And so I'm going to close out with where I started. Again, Mrs. FNO lost 25 pounds and she walks now 2.5 miles, at least 2 to 5 miles a day, 6 days a week. She monitors her blood pressure. She was 76 years old at the time. On May 27th, she will be 80 years old. She's a drama queen. She's off metformin. She's only on 2 blood pressure meds. She always competes with me. She wants to say, "This is my blood pressure." So again, I just want to thank you all for your attention. There are, as I said, a lot of people who are involved with this, a lot of funding that has gotten us this far. This technology is now part of our Morehouse Choice Accountable Care Organization, working with the care coordination model. And again, I want to acknowledge Dr. Priscilla Pima. Go ahead, Dr. Pima, who has done all of this work. Thank you all very much.
Thank you, Dr. Ofili, for that wonderful presentation. I'm energized. I want to download that app right away. So, how about you all? Who needs Fitbits? Sorry. All right. Moving right along. Our next presenter will be Dr. Pamela Bradt. Did I get that right? Yeah. Okay. She said like Brattsworth. I don't want to remember the name. So, Dr. Pamela Bradt has served in senior scientific leadership positions in industry, academia, and clinical practice. She has a special expertise in evidence strategy planning, health economics, and clinical outcomes, pharmacoepidemiology, as well as evidence-based decision-making for products and devices. She has a 25-year broad-based research experience using a variety of study designs, has served as a faculty at a number of national and international workshops on evidence-based medicine, and was the first industry physician invited to speak at the World Health Organization on public health research strategies for high-risk obstetric and pediatric patients. So without further ado, please join me in welcoming Dr. Bradt.
Thank you very much. So I'm actually a pediatrician by training and a clinical epidemiologist, which is how I ended up in my current role as a medical director of urology within a large pharmaceutical company. And what I wanted to talk about today really is some unknown risk in Medicare patients who have overactive bladder. So first of all, this project was funded by Astellas Pharmaceuticals. I'm an employee of Astellas, but we partnered also with the NMQF here. Also just want to say that what I'm presenting today is my perspective as a physician, a clinician, and a clinical epidemiologist, and does not reflect the position of the company. So obviously I have too many slides for 10 minutes, so we're going to just go right through these very quickly. But the bottom line is that I want to touch briefly on urinary incontinence and how important this is in the broad patient population, but also in the Medicare population. A little bit about the unexpected burden of incontinence, and most importantly, potentially inappropriate medications that are prescribed to the elderly population. So first of all, urinary incontinence can result from many, many things. The differential diagnosis of this is pretty broad. It's been estimated to impact about 15 to 35%, depending on the study, of the adult ambulatory population. In men, the prevalence is much lower than in women, anywhere to about 3 to 11% overall, with urge incontinence accounting for the majority of the cases. And in women, the prevalence increases with age. It's as high as 28%, even in young women in the 30 to 39-year-old category, and up around 50% once women reach about age 70 and above. One of the big take-home messages here is that urinary incontinence is not part of normal aging, and that is a major roadblock for many, many patients, and there are some pretty important implications to that, which we'll talk about briefly. Overactive bladder is a diagnosis that overlaps with urinary incontinence. It is not a subgroup of urinary incontinence, but an overlapping problem. It's actually defined as urgency, with or without urge incontinence, usually with frequency and nocturia in the absence of underlying metabolic or pathologic condition. So the group of patients who have OAB are really very heterogeneous, and the fact that we don't understand the pathology, in my opinion, really represents the fact that there's a lot more that needs to be done in this particular space. So we've talked a little bit about the prevalence of urinary incontinence, the prevalence of OAB, again, fairly similar, about 38% of women in their early 40s and about 50% in women in their 70s. In men, it's about 16% for men in their early 40s, and again, close to 50% by the time that men reach their 70s. So just a little bit about our collaboration with NMQF. We really wanted to understand at a very high level basic information about the prevalence of OAB, the rate of medication treatment for this problem, and to better understand the potentially inappropriate medication prescribing in this population. So we used the 2013 Medicare data sets. We identified patients who had OAB. We looked at race, we looked at age, and then we also looked at geography. What you see here is actually quite startling. I mean, in a Medicare population, given what we know about the epidemiology of overactive bladder, it's really shocking that you see very little orange and red on this graph, on this map, because those colors represent 10% up to 12 or 13% or higher of folks who have this condition. We know that it's much higher than this. So this is actually a bit concerning. Not surprised to see the orange showing up in Florida, but it is surprising to see so little orange across the country. What that looks like in numbers is that overall, the prevalence rate of OAB among the Medicare population was only 7%. It isn't that the Medicare patients are protected, right? It's that they're not being diagnosed around the incontinence problems. So we only see about 7% of men and 6% of women Medicare patients who have this diagnosis. The ages, only 5% of those 65 to 74 are showing up as having this, and 9% of those 75 and older. And really, really low rates when we look at race. Not surprising, the highest diagnosis occurs in the white population at 7%. That's still quite low. But when we look at, for example, the African American population, it's only 5.8%, which is extremely low. So every disparity that we might see, we're seeing at the highest levels here against gender, age, and race for overactive bladder and incontinence. So just briefly, the American Urological Association has had treatment guidelines out on this for quite some time. And just as a side note, there are also a number of quality indicators around incontinence. Unfortunately, one of the challenges around the quality indicators is that depending on what medical specialty you're in, they look a little bit different. So I think that's definitely one barrier here. First-line therapy is behavioral therapy. And number one, as you know, there's so much other comorbidity going on in this population, like diabetes, like hypertension, that urinary incontinence often just gets neglected or left out. If the patient doesn't bring it up, often the physician doesn't bring it up, or there's just no time. Everybody runs out of time to talk about this. And so by extension, there's usually often no time to go into detail about how to change behavior to manage this. I will tell you, having been in research for quite some time now in the pharma space and in academia as well prior to that, it's pretty hard to come up with an intervention that separates out from placebo. In the OAB space, that placebo is really behavior therapy. Behavior therapy is remarkably effective in this condition, and it is extremely difficult to separate out intervention from behavior therapy because it is so effective, and yet it's so difficult to get implemented into practice. Second line therapy is oral and transdermal preparations, and those are always more effective in addition to behavioral therapy. And then finally, if those things don't work, there are definitely more invasive third line interventions. So when we look at treatment rates, what we're looking at are the two classes of oral and transdermal therapies that are available for incontinence. And OAB, we're looking at antimuscarinic therapy and beta-3 adrenoceptor agonist therapy. And again, what I would really like to see here is that for the majority of patients who have this problem, that they're actually receiving treatment. But what you see here is that the majority are not. So a relatively small number of folks are being treated for this. And what this looks like specifically is that the overall medication treatment rate is only 21%. And again, you see large gender disparities here. Only 13% of men are being treated for their overactive bladder, 29% of women. And you do see age disparity as well as race disparity. The Hispanic population has the highest rate of treatment at 29.5%. Unfortunately, there's a downside to that, which you'll see in just a minute. So there really is an unexpected burden of incontinence and OAB in the population in general, and I think specifically even more so in the Medicare population. First of all, women with urinary incontinence have a significantly poorer quality of life than their counterparts. So many of them also experience sexual dysfunction as a result of this. It often goes right along with depression, both in men and women. And it's interesting because until you actually talk to patients who have this, who have incontinence problems, it is really difficult to understand the impact that it has on their lives. So it is a much bigger issue than what anybody really realizes. And for those folks who are working, up to 23% of women take time off from work because of that incontinence. What I find to be particularly disturbing is that incontinence is also one of the many reasons that people get admitted into long-term care facilities. And I think this is just an absolute shame to be pulled out of your home and put into a long-term care facility. For those who are already in long-term care, about 60 to 80% of women and 45 to 70% of men have incontinence issues, which we all know lead to other problems down the road. We also know that about 10% of men and 6% of women who get admitted into long-term care are put in there because of urinary incontinence. It's terrible. And then finally, what we also know is that in one study in Northern California, that folks who were admitted to long-term care, for women, they were 2 times greater to be admitted into long-term care and 3 times greater if they were men to be put into long-term care because of their incontinence. So, I'm not moving forward. Thank you. So finally, last piece for potentially inappropriate medications. I think this is kind of the take-home message that the anticholinergics are prescribed for a variety of reasons. Just quickly to remember way back in medical school, that the acetylcholine, very first neurotransmitter ever discovered. And I'll tell you what, a lot of medications are based on that pathway. These medications are associated with adverse cognitive effects, which we saw really start to get our attention based on the Gray article in JAMA in 2015. We know that more than half of elderly patients use at least one anticholinergic medication, and they can be particularly sensitive to it, in part because of their metabolic and physiologic changes. And so based on the 2015 American Geriatrics Society, the Beers criteria, we took a look to see what impact this was having on patients with overactive bladder. In a study that we did and published, we found that for every 1-point increase in anticholinergic burden score in patients who had OAB, there was a 13% increase in risk in cognitive impairment. Just from that 1 point. There's a 9% increase in risk in an inpatient admission, and there is an increase for every 3 points of an additional visit to the doctor. So the impact is pretty significant just by increasing that anticholinergic load. Falls and fractures are really important here. The use of PIMS, potentially inappropriate medications, is associated with an increased risk of falls and fractures. And we see that postmenopausal women, age 65 to 79, have an increased risk of falls and fractures associated with that PIM use. We also see it in the overactive bladder population as well. So what we found in the patients with OAB is that 25% in one study, up to 50% in another study, experience a fall or a fracture in 1 year. And that's because of that urge and that getting and running to the bathroom so that they don't have to deal with the incontinence piece. So it's pretty significant. So finally, we looked in the Medicare data set at the potentially inappropriate medication use. I'm going to just move on here. What we see is 28% prevalence of potentially inappropriate medication use in patients who have overactive bladder. That's really, really high. And we see also this breakout in terms of gender, race, and age. So in summary, there's a misperception that incontinence is a normal part of aging. Overactive bladder appears to be underdiagnosed in the Medicare population and undertreated. Patients with OAB have an increased risk of falls and fractures. The use of PIMS in Medicare patients was 28%. This is associated with an increased risk of cognitive impairment as well as falls and fractures in and of itself. Hispanic women ages 75 and older were at the highest risk for exposure to PIMS, and these findings highlight the unexpected burden of OAB in this population. Thank you.
Thank you, Dr. Bradt. Interesting numbers, which I'm sure there'll be a lot of questions after. So we have our final panelist, who's another colleague and friend of mine, and is well known in cancer, in her contributions to cancer research. She's definitely a luminary in the field, Dr. Edith Peterson-Mitchell. Clinical professor of medicine and medical oncology and program leader in gastrointestinal oncology at Thomas Jefferson University. Dr. Mitchell has received 21 cancer research and principal investigator awards and serves on the National Cancer Institute Review Panel and the Cancer Investigations Review Committee. She is the past president of the National Medical Association, and she serves as the NMA representative to the Minority Affairs Section Governing Council of the AMA. So, Dr. Mitchell.
Thank you very much, Dr. Clark, and good afternoon to everyone. So I'm going to talk today, of course, about cancer. But what I want to emphasize is the improved survival, but continued disparities in cancer care in this country from the 1971 National Cancer Act through Moonshot 2017. My disclosures. Now, I always ask the audience to work with me. So, question for the audience. Cancer mortality rates have decreased over the last decade by 12%, 16%, or 22%. Just raise your hands. A, B. Few, great. C. More, okay, thank you. And the causes of cancer disparities are social injustice, poverty, low economic status, culture, possible influence on the gene-environment interaction, all of the above or none of the above. Number one, A, few, great. B, C, great. And D, okay. Methods of improving cancer survival rates include A, prevention, B, early diagnosis and treatment, improved treatment strategies, post-treatment quality of life, survivorship and surveillance, all of the above, none of the above. So how many for A? B, C, D, E, F, and G. Some for G, okay, great. So the trends in the death rates from cancer have really decreased tremendously over the last few decades. Note the decrease in stomach cancer, tremendously low. Prostate cancer, lung and breast cancer, all of these have shown tremendous benefit over the last decade. And if we look at those death rates among females, note the significant decrease in breast cancer, decrease in lung cancer, again, gastric cancer and others. However, if we note the data for African Americans, whites, and all, note that for every single cancer, the death rates or overall survival rates for blacks are lower than for whites in this country. Oops. And to address that, the National Cancer Institute and many other cancer groups around the country have addressed this. Dr. Harold Freeman indicated from his work that cancer wasn't just due to one thing, and that overall survival rate, therefore, must be addressed in a multidisciplinary fashion because poverty, culture, social injustice, and possible influence of all of these by the gene environment. And if we are to address them, we must look at prevention, early detection, diagnosis, treatment, and then post-treatment care and data. If we look at incidence rates for men, note that Black men in this country have the highest incidence of cancer of any group. And if we look at everyone, again, noting mortality rates for Black men are higher. So incidence rates higher, mortality rates higher, and consequently overall survival. So what we have, National Cancer Act was formed and approved by Congress in 1971 and moved forward to 2017, and we have the Beau Biden Cancer Moonshot. It was initiated in the Vice President's office and brought together many individuals and all of the federal agencies involved in cancer. So this is a federal task force with the Veterans Administration, the NIH, and others. The group is, the Moonshot is administered by the National Cancer Institute. It is approved by the NCAB, and the Blue Ribbon Panel is the one to form what are the key initiatives that we should be involved in this country, and how can we all function with them. These are the overall goals of the Moonshot, and why now? Because it's time to review these. We have all of the data. Data have been collected for groups, and therefore this is the right time. And President Obama gave this information in his 2015 State of the Union for Precision Medicine and 2016 for the Cancer Moonshot. These are the goals, and I won't go over them all, but there is a full report here at this website. Oops. So note that this is the 28-member Blue Ribbon Panel, and note that we had the opportunity to be with the then Vice President at that time on this panel to define these initiatives. I won't enumerate these, but these are the various initiatives, and one was creation of a data system where we know we have many computers, and none of the computers can talk to each other, but this was to define a data system that we can utilize where computers talk with each other, and therefore we've got that information. Pediatric cancers, symptom management research, and one part that we insisted was there that disparities should be included in every single initiative. So all of these initiatives, very important, but the fact that disparities should be a major component of each, and we were able to get that through the National Cancer Institute and NIH, so it's a part of the plans that are ongoing at this time. So the implementation part of this, cancer health disparities at the top. Because if we don't figure out why, for example, African Americans overall have a higher incidence of cancer and higher death rate, but African American men, of all of the subpopulations of patients in this country, African American men have the highest incidence and the highest mortality rates. So these were three that we felt were ready to go at this time. Colorectal cancer screening If you look at colorectal cancer in African Americans have a 20% higher incidence of colorectal cancer and a 40% higher death rate. So colorectal cancer is one of the first. Tobacco cessation, tobacco influences cancer mortality rates for a number of cancers, and then for the HPV-related cancers, HPV vaccination. So these will be ongoing. And we were so pleased that last year, December 14th, Congress passed the funding for this initiative, and then President Obama signed it before he went on Christmas vacation. So this is the funding, $1.8 billion over 7 years, with $300 million given for the initial FY17. So that is ongoing now, and therefore we have the funding for this initiative. And what I want to say now, we got the answers. We know that over this time, over the last decade, cancer death rates have decreased by 22%. And if we are to continue that, we need the research. We need to make sure that members of our community are included in the research, both in terms of prevention, screening, cancer treatment, and cancer survival, and of course, the causes of disparities and the methods of improving cancer survival rates. So now we are in April of 2017. What we have is that the budget that is going to be discussed and perhaps voted on this week decreased cancer research and NIH, well, overall NIH research by 20 to 25%. And that is something that cannot happen. And what I want everybody to do, again, I said I like for audience participation. How many people got a cell phone? Raise up your cell phones. What you can do today, I know we'll go home with all of the information that my colleagues have presented and I have presented. We'll go back to our practices and our jobs to address cancer in our patients. But there's something we can do today. Pick up your cell phones. Everybody, call your congressional representative and tell them not to decrease NIH funding, because this decreases our research and our advantages over the last years, and consequently, this will do harm to our patients, to our communities, to our nation. And one of the things that we know in medicine is what? Do no harm. So pick up your cell phones, call your congressional representatives, and tell them what you want them to do in terms of votes. Thank you.
Thank you, Dr. Mitchell, for, again, a wonderful presentation. I felt like I was at church, a call to action. Now we just need to pass the collection plate. All righty. All right. So I'm going to give some closing remarks, and then we're going to open it up for questions. So the themes that I took away from our panelists' presentations today, which were all excellent, before I get into that, let's give them a round of applause. So how do we improve the themes that I took in terms of promoting health quality and extending, in terms of life expectancy? One has to be education. Two, there has to be collaboration, especially with community partners. Three, technology is essential. We know that, especially in today's world, everyone does have a cell phone, social media, Twitter. Dr. Dion Hart is the master of Twitter. Shout out to her. But we also know that there are barriers. Time, okay? I can't tell you how often it infuriates me that I only have 20 minutes to do a medication management for my patients. I don't like that because I'm convinced that we're more than just a bag of chemicals, as my mentor would say. You have to kind of get down to the nitty-gritty and really talk to patients, but we're not giving them enough time. I wish we had 30 or 40 minutes to see every patient, but that's not feasible in the current payer model and things. But we have to talk to our patients. And then again, it has to be community engagement. And I hope that we do take that call to action and do contact our congressmen and women, because this is an important topic. So with that, we will open it up for questions. Dr. Anthony.
Thank you all for your presentations. Thank you. My question is for Dr. Niva Lubin-Johnson about PrEP. Can you talk about the cost to the population in which you tailored your presentation, and also if it's been shown to be effective not just in HIV prevention, but also for HSV, given the types of drugs?
The second question was related to HSV.
Herpes simplex, because
I have not read any data in terms of it being effective for HSV.
Okay.
Okay.
And the reason for the question is a lot of patients who are high risk can't afford Valtrex, so we're doing a lot of acyclovir. And so that's kind of the thought where that came from. And then the last question is about research in minority populations, specifically for women, around the acceptability, the knowledge and use of PrEP.
So actually, there's a recent, now I'll go backwards. So number 3, recent study done that actually showed that women who were HIV positive were discouraging women who were HIV negative from doing PrEP therapy. Don't know why that is so. It could possibly be the side effects with HIV therapy, but it's much less with PrEP because there's not as many medications involved with PrEP. In terms of cost to population, that's one of the issues with access. In particular, if expanded Medicaid goes away, that will probably decrease access for women who need it. Most women now are either getting the medication through Medicaid expansion, or if they are employed and have commercial insurance. So those are the ways they're most often able to get it, unless they're at an FQHC where there's some special program that would allow them to get it. So to answer your questions. And by the way, I have to give a shout out to my staffer, Craig Johnson, for the slide presentation today.
Dr. Midday.
This is for Dr. Ofili. There are lots of apps out there for people to improve their health, for people to improve their health care. How do you help the patients determine which is the best, and how do they wade through the morass of health apps out there to try to improve their health? And are there some apps that you've seen that potentially have not been so helpful?
Yeah. So I think that there's a sort of several parts to that question. So some apps are just sort of messaging apps, where some connect to technology like ours does to measure physiology, and some claim to just get the physiology through the app. So there's actually an app, not just the viewer rating, obviously that has validity because people who've used it will say something, but there's also now increasingly a site that sort of checks out apps. It's just not consistently done. And it looks like the FDA, a portion of it would be regulated once you start interacting with the clinical space. And so I think that apps that are doing those sorts of interactions may wind up having a little bit of a leg up as opposed to just the usual consumer apps. It's a very crowded space, but we are trying to distinguish ourselves to get more into the clinical space because our technology can work working the doctor side as well? Thank you for the question.
Other questions? Here, Mike.
Hello, my name is Katrina Rhodes. I saw a statistic with the overactive bladder and urinary incontinence. I believe it was about 23% of women took time off of work for that. And I was wondering if you could talk more about the relationship with depression, if there's any consideration for it as a disability and the impact from time or time loss due to that.
Thank you. Yeah, absolutely. Depression is actually, both in men and women, is a very significant comorbidity with incontinence. It's actually very significant, and the greater the impact on quality of life, the greater the depression. In fact, some folks don't leave their house at all because they're so worried about incontinence episodes. I have to say that I was actually shocked as I got into this space and started to learn more about it, how significant it is. The other piece that's related to that is that there's a real disconnect between in the dialogue between the patient and the physician, so that when the patient feels like they've expressed their concerns about incontinence, the physician feels like they've heard it and addressed it. When you get them separated and you talk to them separately, the patient ends up leaving not having the problem addressed, and the physician feels like the problem was solved. And so this continues on, and it does lead to high rates of depression, which does account for work loss. There are actually a whole number of factors that contribute to that loss of time at work around incontinence. So thank you.
I think I got a sign that we are wrapping up. Is that correct? Okay. All right. So thank you all for joining us today, and we hope that you continue to enjoy the rest of your day.